Okay, but here now, let's go to slideshow. There we go. Okay, guys, so sorry about that. We'll get restarted. I'm going to start recording again. I just didn't want to have all that on the recording. Okay, we are recording.
All right. So the phrenic nerves, you can see how they kind of wrap down both sides of the heart there. When we're putting in pacemaker leads, some patients will complain of the hiccups, like the thumping on the left side. Women will describe it more as like a baby kicking them on the left side there. Men have no idea what that feels like, so they call it a hiccup. And typically what it is there's a lead that's out there we're providing energy for. We don't know where the phrenic nerve is exactly when we're putting leads into the heart, but the heart's kind of rotated sideways and we're putting it into the RV. And sometimes we put a lead out in the coronary sinus to get a biventricular pacing. Any one of those lead configuration can capture that phrenic nerve. So if somebody's complaining of that hiccup in the middle of the night or something like that, every time they lay on their left side, it's probably a phrenic nerve stimulation. I can make adjustments to it to try to get it to go away, because typically I don't want a patient to live with that. So knowing where those phrenic nerves are at and what they do cause, is important. Normal heart conduction, our electrical activity starts up in the SA node and travels down through an AV node, goes through the Purkinje fibers and the bundle of His, and on down through the conduction system, right bundle and left bundle. Why do you need a pacemaker? You need it for two reasons. Either your sinus node has disease or your AV node disease. So sinus node disease, you get sinus arrest, a nice long pause. AV node disease, you get your P wave still going through, but no ventricular conduction, or a 2-to-1, 3-to-1 Mobitz or something like that. So why does a patient have a pacemaker? Well, if it's sinus node disease and their AV node is semi-healthy, as we get older, our AV node gets worse and worse, but they may have a long first degree, but as they get faster and faster, they may winky buck. And if you see a winky buck, sometimes I treat the nurses more than I treat the patient for why they're in the hospital, because I don't want the phone calls at 2 o'clock in the morning and saying, hey, it's normal pacemaker behavior. But every once in a while, you'll see a missed beat and you might get that ventricular delay and it looks like, oh my gosh, the heart rate dropped into the 40s. Why did that happen? Well, it's looking for conduction, but it would pick back up on the next beat and be able to go on through. So this is doing the cellular anatomy of it. Some of this is for brand new nurses that have come into it. So the SA node sits up in the top of the right atrium. It's the natural pacemaker of the heart. And then the AV node sits down there in that groove between the A and the V. The AV node, and the junction there, that's where you're going to get those junctional escape beats, and they kind of go up and down at the same time. So if I have a pacemaker in, I can see electrical activity in the A and the V, but they're happening at the same time, usually 40 to 60 beats a minute. Bundle of His just below there. If you're getting that ventricular escape rhythm, which means that the electrical activity is actually coming down much further in the left or right bundles there. So SA node, you get the P, the QRS for the ventricles. Bradycardic indications, so there's going to be the SA node or the AV node. You get the sinus arrest, sinus bradycardia. Chronotropic incompetence is a real thing for a lot of patients. If you're getting out and you're exercising, you never get your heart rate above 60 beats a minute, and that's exercising, that's a problem. You're not getting the oxygen demand to your heart that you actually need, or you're not getting the oxygen demand to the body that you actually need. So sometimes we'll put a pacemaker in just for the chronotropic incompetence. Usually a treadmill test is a good way to indicate if they're having that. Brady-Tachy syndrome, you actually probably see this a lot in the hospital. Somebody's in atrial fibrillation and then all of a sudden they convert to a sinus. and they'll get a long pause, and then they go back into atrial fibrillation. Their heart rate's 130s, 140s, 150s, and then they convert again, and they have that long pause, and they just Brady way down. So that is an indication for a pacemaker as well. Sinus arrest, that's SA node just failing. Sinus bradycardia, under 60 beats a minute, and then the chronotropic incompetence. You can see that, normally our heart rate gets up whenever we do things. If we were to walk down the hallway, our heart rate would be up, but some patients just cannot do that. So this is the Brady-Tachy syndrome, where they go into that atrial fib and just really speed up and have that bradycardia whenever they're in normal rhythm. Exit block, first degree AV block, second degree Mobitz 1, Mobitz 2, and your third degree. So this here is a first degree AV block, just a PR interval greater than 200 milliseconds, not an indication for a pacemaker, nor should we ever put a pacemaker in for somebody that has a first degree AV block. Second degree Mobitz 1 is still not an indication unless they're symptomatic. So a patient can have Mobitz 1, but if they're not symptomatic with it, we do not put a pacemaker in for this. The 2-to-1 heart block, this is your Mobitz 2, 2-to-1, 3-to-1, whatever it is. This is an indication because this is AV dysynchrony. Typically, every time your atrial beats, you want your ventricles to kind of kick in. That way, you're not kind of pushing back and forth on the tricuspid valve. So I think this had. Normally would play an electrical activity down through everything. Third degree heart block, this is complete AV dissociation. So when you think of third degree heart block, just think of your A's and your V's. If you map them out, and you can map them out long enough, sometimes your sinus node is just fast enough that extra beat looks like it's lining up. But if you watch it long enough, there's no AV dissociation there. So normal sinus rhythm, normally that would play, and these would play as well. So level of evidence, when our electrophysiologists or cardiologists go in, they need a level of evidence to justify a pacemaker. So class 2A, 2B, and 3 are most evidence. Class 1 is absolutely not. Types of pacemakers, so there is a single chamber, and when we talk about a single chamber pacemaker, I'm going to pull this one out, and I'm assuming that you guys can see me in the video here. At the top here, there is a header to this pacemaker. There is 2 ports on this one. There's a place for the atrial lead and the ventricular lead out there at the end. On a single chamber, there would just be a ventricular port. In Europe and other places, they do have just an atrial pacemaker, but in the United States, it's not FDA approved to put just an atrial only lead. So anytime there's an atrial lead, there should be an RV lead, unless it's off-label. But in the past 5 years, you guys may have seen something like this. And this is a micra. It actually goes inside the heart. We take it through the groin, and we deploy it into the septum of the heart. You can see it has kind of like fish hooks on it, and I'll pass this around the room here in a second, but it has fish hooks on it. When it's in the catheter like this, and it comes out, it grabs into the tissue of the heart, and we do a tug test on it to see if we can get some flex on there to make sure how many is in. But when it is in the heart, it's not going anywhere. So these are actually very, very good. This concept was actually 1980 in a science magazine. However, it took us till 2017 to be able to get the technology to make that happen. The problem is nobody wants to have this done every couple years. So battery technology was huge, and now we got a lithium hybrid, which is actually the same technology we use in these pacemakers, but the microchip and the processor got small enough that we could put it inside this. So we took all this and put it inside this, minus a considerable amount of features that we consider important these days, like Well, what happens when the patient has a high ventricular rate arrhythmia? Well, this isn't going to show us that. It actually is a very dumb pacemaker. It paces, it works. It's kind of like our pacemakers back in the 1980s. They didn't give us a lot of information. They told us, do they work or do they not work? That's it. Now we're, and these pacemakers are like, well, what time did the arrhythmia happen? What time did it start? What time did it end? You know, how many PVCs are they having? You know, and they can give us all kinds of arrhythmia detections in this, but the battery, this one's going to last longer than this one. So this one's somewhere between 12 and 15 years, and this one's between 10 and 15, depending on what you're using. So those can be, this is a single chamber pacemaker only. It is, we don't have one that goes in the right atrium. What we did find out is if we did try to put it in the atrium, we just tear the tissue and nobody survives that. So we moved away from finding something that will work in the atrium for now. Oh.
Gina asked, can you clarify the heart rhythms that do get a pacemaker as they positive 2 to 1 and 3 to 1 moments bradycardia syndrome?
Yes, so all those. So sinus brady is a no, Mobitz 1 is a no, but anything past Mobitz 1 is a yes. So Mobitz 2, 3 to 1, 2 to 1, whatever it is, that is a pacemaker indication. Symptomatic Mobitz 1 is an indication. So if the patient, sometimes you lead to chronotropic incompetence. If you're giving Mobitz 1 at 120, you know, we all will get Mobitz 1 at some heart rate. So 220 minus your age is typically your maximum heart rate. So make math easy. 220 minus 50 is 170. If I were to go out and hit, you know, take off running, I'm going to hit that Mobitz 1. Well, that doesn't require me to have a pacemaker. And some patients, as you get older, you know, that Mobitz 1 moves down the line there. When some patients, when they hit 100 beats a minute, they get Mobitz 1, and that's okay. But if you're Mobitz 1 at 60 beats a minute, you're going to move into 2 to 1 at probably 70 or 80. So that would be an indication for a pacemaker. So it just depends on where that Mobitz 1 is, if they're symptomatic, how mobile they are. You know, if they're 90 years old and bedridden, they have Mobitz 1 at 60 beats a minute, leave it. You know, we're not fixing anything at that point.
Is there an age limit on when they would put a pacemaker in? I feel like there used to be.
No.
Okay.
So quality of life, and it usually comes down to family. So is there an a time where you say you don't put a ventilator, you don't do CPR? Well, it's dependent on every patient. So my oldest patient, she was 103 years old. So, and she got a dual chamber pacemaker, and you know, how long she lived after that, I don't know, but you know, she was alert, oriented. She was like, well, if this is going to keep me going, yeah, let's do it. But you know, if we didn't do it, then you pull the temporary and say, okay, when do you want us to turn it off? Have everybody come in and say goodbye. So quality of life and a lot of other factors go into it. But did I answer the team's question? Okay. And does those questions usually pop up over here, or do you need to tell me?
I'll probably have to just tell you.
Okay. Dual chamber pacemaker system. This is where we're going to pace the atrium and the ventricle, and you can see the EKG strip down here. And most everybody here has the monitor up above the head, and you can see the pacing spikes come in, and you'll see the blue spike and the two blue spikes right next to each other. And that would indicate your atrial pacing and ventricular pacing. You can kind of see in the diagram there, a lead is setting up in the right atrium and a lead down in the RV apex there. This is another view kind of in a 3D model where you can see the lead up in the right atrium. Chest x-rays are great to be able to figure out what kind of pacemaker somebody has. Open up the chest x-ray, you see the chest x-ray off to the right here. You can see that this is a right-sided pacemaker, which is unusual, but we do them on occasion. But you can see the lead that's sitting up in the right atrium. You can see the lead that's sitting out in the right ventricle there. We do not put anything in the left side because that is oxygenated blood. It clots. If it forms a clot around a lead, it would shower it to the brain. Everything stays on the right side for us. Or through a coronary sinus to get us on the left side, but it's still in a vein that we utilize. So that's pointing to the right atrium, right atrial lead, and this is pointing to the RV lead. So this, getting into the biventricular system here. Why do we put a biventricular in? Usually it's because you have a right bundle branch block or a left bundle branch block. That one's kind of an iffy one, you know. Or if we put a dual chamber pacemaker in and they're going to 100% RV pace, we know at some point in time we are likely to cause heart failure because we are causing a left bundle branch block by RV pacing. We're only getting into that right bundle when we're sitting on the right side with a lead. So over time, you get that dysynchrony. Well, your heart just kind of does this the whole time, you know, and over time, it just gets worse and worse. Your heart should be squeezing everything at the same time. That's how your heart's supposed to function. So at the beginning, when we put in a dual chamber pacemaker, their heart function has to be above 45% for 2-lead. If it's below 45, we can consider that we put in a third lead at that time. But if we know they're going to 100% RV pace, they have complete heart block, they're going to pace all the time, they still say you got to wait until their heart function drops before you can add that third lead. So there's where the indications lie to put in the third lead. Anybody who is wide QRS complex, which can happen with pacing. We know that if somebody's pacing in the RV, you get that very wide complex and a heart function less than 45. So you want the automaticity of the domino effect of running down the SA node to the AV node. These are the codes, the NASB, the NBG codes here. So when we call to the clinic, we go, okay, the patient is DDD set up 60 to 120. Well, what does DDD mean? You know, so the first one is where are we pacing? So if it is D, that means we're pacing the atrial and the ventricle. If it is VVI, we're pacing the ventricle. And if it's ODO, we're not doing anything. We're not pacing anywhere. If it's AAI, not approved here in the United States, but if it is AAI, we're only pacing in the atrium. So the second one is where are we sensing? What are we doing to this? So the first one is where we're pacing. Next one is where we're sensing. So if we're not pacing, we have a window, and every pacemaker has a window. The pacemaker, when we say 60 beats a minute, that's 1,000 milliseconds. After 1,000 milliseconds, that's my window. If I didn't see anything at 1,000 milliseconds, I provide. If I see something in this 1,000 milliseconds, that is a sense beat. So I move over my window. The next one is the response to it. Are we going to inhibit or are we going to trigger? What does that mean? Technically, we do not use trigger very often. So really the inhibit is what we do use. The trigger would mean if I see a ventricular complex, boom, I'm going to come in, 20 milliseconds after I see that and provide a beat. Why would we do that? Usually it's because we're trying to get that left side to come across as quickly as possible. The next one is that rate modulation, which means there is a sensor in a pacemaker. The sensor says the chronotropic incompetence person, we're going to go with them for the moment here. I can't get my heart rate up as I walk down the hall. So how do we mimic somebody's own heart rate to be able to get up and walk it down the hall? You all can walk down the hall, get your heart rate up to 100, 120, 130, whatever you want. Somebody with a pacemaker, chronotropic incompetence, they can't do that, so you put a pacemaker in here. It's called a piezoelectric crystal. What happens is that it's kind of like a diving board, and as you're up and moving, the diving board starts bouncing. The more it bounces, the more you're moving around. So that helps your heart rate get up and get going, and it mimics. As soon as you stop moving, well, we don't go, well, drop the heart rate back to 60 beats a minute. We mimic everything, so we got a plateau there, and then we gradually curve it back down the moment that you stop moving around. So we do, that's the sensor in the pacemaker. So if I'm going to throw up things like DDDR, that means we are pacing in the ventricle and the atrium. We're pacing, they're sensing in the atrium and the ventricle. We're going to inhibit in the atrium and the ventricle, and we're going to do rate response either in the atrium and the ventricle both. So it kind of depends on what they're needing at that point in time. Multi-site pacing, that's kind of a newer thing that don't really have to get into much on that. I don't think we ever call up that, hey, we're doing multi-site pacing. That's more for the pacemaker rep or the electrophysiologist to worry about. So just those first 4 are the only thing you have to worry about. If we call up and say their VVIR 60 to 130, that means, that they're pacing the ventricle, they're sensing the ventricle, we're going to inhibit, but the rate response is on, and that's that 130. So if they get up and start moving around, they can get their heart rate up to 130. If it's VVI, well, and we set it at 40 beats a minute, because some patients just don't need the pacemaker that often, or if it's a defibrillator, we set it low so we're not pacing. If you see somebody with their own heart rate in the 70s and don't see any pacing spikes, is the pacemaker working or not working? It's working, and it's working fine. It's how it's programmed. So patients will have their own heart rate. In fact, we did a micro yesterday, and I couldn't tell this morning if the patient was paced or not paced because they have a left bundle branch block with pacing and without. But when I was able to pull up the pacemaker and say, oh, well, she only used it 34% of the time, 66% of the time she was not using it, she was on her own. So at some point in time, she got her own AV conduction back. And preferably to make a battery last as long as it can, I want you to have your own heart rate. That's great. I can make a battery last almost 15 years if you have your own rhythm. But if you need it 1% of the time, and that keeps you from passing out and killing somebody on the road, killing another family, that 1% is very, very valuable. And I have patients like that. They have neurogenic syncope, vasovagal syncope, which means that, they just all of a sudden just pass out. Well, they need it 1% of the time to keep them from doing that. That's very valuable. Patients will come in and say, well, is 1% good? Is 100% good? It doesn't matter. It's what you need it for is good. So if you needed a pacemaker and you're using 100% of the time and it's keeping you alive, I guess that's good. More of the NASB and the NBG codes. So this is kind of a little bit of technical input to the pacemaker, and this is VOO mode. VOO is where are we pacing in the ventricle? What are we doing? Are we sensing or not? We are not, and we're not inhibiting. So VOO, DOO, basically we're blinding the pacemaker. We're saying, I don't care what I see, I am pacing. So I'm not looking for anything, and it is, say, VOO at 60 beats a minute. You will see a pacing spike at 60 beats a minute regardless. Now, does it capture or not capture? If you had your own intrinsic conduction that came through, your heart is squeezed, and I throw a pacing spike right now as it's squeezed, that pacemaker's not going to make it squeeze again. You can't squeeze something that's already squeezed. That's a functional loss of capture, and that's completely okay. And pacemakers will do that from time to time because they're looking, and by the time it didn't see your heart rate come in, so it's providing, but your own heart rate comes in at the same time. That's a functional loss of capture because your own heart rate got through and squeezed first. So this one's kind of showing that, does my arrow show up? No? All right. I'll show up here. You can see that this one, you had your own QRS complex in here, but you see the pacing spike here? That's VOO. It can't see that you had your own rhythm, but it tried to provide a beat regardless. And it couldn't capture because the heart's already squeezed. It hasn't made it through that resting phase yet of refilling. So, and then you can see it captured here, another functional loss of capture. This looks like PVC, and we captured again. So our timing cycle is exactly the same all the way down because it's VOO and it's programmed to do that at that point in time. This is VVI. So here we're actually looking for it, and you can see that the timing cycle moves. The window moved down. I saw my QRS, I moved down, saw the QRS, moved down. I didn't see anything in that timing window and provided a beat. So, and then it times off of that PVC as well because I can see that PVC. Now, does a PVC always perfuse blood to to the finger or your pulse ox. No. And 99% of the time, our nursing homes will see a patient, they say their heart rate's in the 40s. Well, they bring them in and they have a pacemaker, and they'll say, well, the pacemaker's not working, the heart rate's in the 40s. They'll bring them in, put them on a monitor, and all of a sudden you see pace beat, PVC, pace beat, PVC, pace beat, PVC. Well, you can't do anything about bigeminy, and the bigeminy, the PVC is not perfusing, so they're not picking it up on the pulse ox. You put them on a monitor, and all of a sudden their heart rate's 80, and the pacemaker says that's perfectly normal. You have your heart rate in the 80s. That's a good heart rate. So it's only providing every other beat. This is DDD. We're providing the pacing beats in the A and the V. You can see that the atrial pace on that second beat there got through to the AV node and got through. So it had its QRS, the native QRS. The next one is an atrial pace and a ventricular pace, and the rest of them. And the next one after that is a P wave. So it saw the sinus node kick in and then provided a ventricular beat to the AV node, to the ventricles. DDD pacing. So you can sense in the atrium, sense in the ventricle. You can pace in the atrium, sense in the ventricle, sense in the atrium, pace in the ventricle, pace in the atrium, and pace in the ventricle. It's the 4 different ways that you can get there. So what type of pacemaker is this? It is 3. So it is a biventricular pacemaker. And I can tell it's a pacemaker because there's no coil on that RV lead, which would be a defibrillation coil. The components, so leads, the can, and when we tell patients they're going to go in for a battery change, it's the whole pacemaker. Pacemakers, the battery is welded on the inside. You cannot get to it. So when we change a battery, it's unplug the leads, set the old one off to the side, take the new one, plug it back in, put it back in the pocket, sew them back shut, send them home. But this is the whole pacemaker. Now, in your Roku remote at home, you have what, 2 AA batteries or 2 AAA batteries. I think those are 2.8 volts each. This whole battery is 3.2 volts. And we make this last 10 to 15 years for somebody who's 10 years for somebody who's 100% dependent. I'll take 2 guesses. How many times on an average day does your heart beat? I'll go with you. Pick on you. What'd you say?
I said 60 beats a minute, approximately, and then how many minutes in a day?
1,800. So
Yeah,
70,000, 75,000.
Okay. Give me another guess. 80,000. On an average, your heart rate will beat 100,000 times a day. So you guys are, at least you got in the realm of everything. Now, multiply by 365 days. That's 3.5 million times that your heart is squeezing a year. Now multiply that by how many years that you're survived. All right. That's a lot of flipping the light switch on. Pacemakers got to do the same. 100,000 times a day, 3.5 million times a year, it's flipping the light switch on. Hook a AA battery up to, or 9 volt. Let's give it 3 times what this battery has in it, 3 times. Hook a 9 volt battery up to a light switch at home, put a 1 watt LED, and see how many times you can flip on and off the light. You will not make it 3.5 million times, let alone 10 years down the road. So this battery technology, very, very good. But there is a cathode and anode to every pacemaker lead. That is where the electrical activity happens. It happens all the way down at the very bottom of the heart, where it's actually attached. When we talk about the circuitry, the very bottom is the battery, then the circuitry is up on top. We actually use the lithium silver vanadium oxide with carbon monofluoride battery. It is a big mouthful to be able to say that over and over. But that has actually been, and actually we tweaked the ingredients just a little bit to be able to get our 15 years out of our newer batteries. But it's still the same combination. What their proprietary combination is, I don't have access to that, nor do I want. So the 6 to 12 years is moved up for us. What is this saying? Leads and insulation. So all of our leads have insulation around them, and there is 2 coils down it. One to make the anode, the other one to make the cathode. So the wires on the inside of there have got to be separated with insulation too, because 2 wires touching each other causes a short circuit. So there is insulation in between the 2 and insulation around the outside. When you look at the leads and the wires, they're all handmade in Puerto Rico. So little Puerto Rican people down there, and they're making these leads with the little wires putting down there. I got the privilege of actually going down there, and I took Dr. Daring with me, and we tried making our own lead, and ours did not pass inspection. So they said fail. And some of it was our label wasn't exactly straight in it, and they're so critical about every aspect of it. They may make 10 leads and throw 2 of them away because it did not pass inspection. So they're very critical about that kind of stuff. The same way with the pacemakers. They get hooked up to a machine right away. They get tested, and then they go down another machine and get tested. So they're tested about 10 times before they actually get put into a box and then shipped out. Let's see. Unipolar pacing. This is where you just have the 1 wire down to the bottom. This is actually very critical for somebody who has actually fractured an outer wire already, and they just have the 1 wire still down there. The problem with 1 wire doing just a unipolar pacing is if I'm sensing off of that, I can pick up a lot of noise on the outside. So pacemakers are sensing things. Environmental noise is a big issue. Whenever I'm sensing in this little area with an anode and a cathode, I don't have to worry about that environmental noise, like that ICU noise that we can cause. But as soon as I take away this cathode and I make this my cathode up here, or my anode, now my cathode to my anode up here, now I'm taking it all the way here, and I have this big, broad visualization of things. So noise environment is a big thing. Somebody's welding, working on alternators or generators, we tell them to stay away from that. Even if your bipolar system, it can still pick that kind of stuff up. So bipolar pacing, just showing that anode and cathode down there. Hey, that one's actually, it's working. So it's showing you electrical activity from the cathode to the anode. So this is showing the filaments on the inside of it, the unipolar lead and the bipolar lead, and you can see the insulation between that cathode and that anode on the bottom lead there. So electrical concepts. Whenever you see an interrogation report, this is what you're looking at. Impedance is a big part of what we do. That's resistance. So not to get too much into that, but if we're really low impedance, we're spilling over our electrical activity. We just flowing it out. There's nothing to resist us from just pushing that current out. When you have impedance on there, the resistance, that makes it harder to get that current out, and a higher resistance is better because it just doesn't throw the current out and actually increases your longevity, and actually can look like kind of like a water hose. So you don't want it too tight, so you don't want to kink the water hose, because then you don't get anything out, but you don't want to leave the hose wide open, because then you don't get that nice spray out of it. So there is a fine line there with the current, and making sure that we're not using too much energy to deliver it, or and then not enough to be able to get the energy out. And we use Ohm's law, which is V is equal to IR, the voltage, the current, and the resistance, the impedance. So this is our sensing signals. When we talk about sensing, and we're going to talk about it with this as well, sensing. What are we doing with sensing? we are going to set a fence up. And so you can see that this one up here is 0.5. This one's 2 millivolts. And I do have something coming up that has it. So you can see that, if I set my sensing somewhere, let's say right in here, I'm not going to see this guy right here, right? So, but I see this one just fine. So setting the sensitivity has got to be crucial to be able to time the pacemaker off. Now, if I set it down here, I'm going to see both of them. I'm going to see that over the top. And we consider our sensing as setting a fence. So how high of a fence do we want? We don't want the fence this high because now we can't see both of them. And so the ideal location would be to set the fence down here where you can't see both of them. That one's showing you that, if you adjust that sensitivity up, that's not ideal either. But what if this is a P wave and we're trying to sense just QRS? That we call that kind of a crosstalk where all of a sudden we're picking up the P wave, probably because we're pacing and that electrical activity is getting down there. Well, sometimes we want to cover that up. Or if this is QRS T wave, we don't want to see that T wave. But if this is a smaller QRS complex, we would want to see that. So this one looks like this says adequate sensitivity. So QRS T wave. So we don't want to see the T wave because we don't want to double count and say, oh, you got a heart rate and your own heart rate's 30 beats a minute because we're over sensing the T wave there. Let's see. Intrinsic beat not sensed, scheduled pace delivered. So I'm not going to worry too much about that. Chest x-ray showing you fractures. Twiddler syndrome. This is, if you guys have an EKG and you guys call me and tell me the pacemaker is not functioning right, I'm going to say, if you guys call me and say, hey, the monitor's saying that the heart rate's in the 30s, I'm going to be like, take a picture of it, send it to me. I'm not making a trip in. Pacemakers don't fail unless somebody makes them fail, like twiddling it out. But pacemakers typically work 99.9% of the time. So for it not to work, you got to convince me. All right. So sometimes it's like, well, the monitor said the heart rate was 30s. Well, was it really 30s? Or was it PVCs that it just wasn't perfusing, couldn't pick up, or your EKG didn't pick up that pace speed or something? Because there's times where I'll see, it'll say asystole, and you look up there and you're like, patient has a heart rate. Why is it saying asystole? I'm not going to go through this. This is a crush syndrome. So sometimes you can see on chest x-rays issues. So you can see in this one that lead doesn't look normal up at the top. And I'm looking for things like this. This one, actually, the RA lead is actually in the RVOT. That was a failure on the cardiologist that put that in, and the rep who was involved in that, because they should have known. This is a Twiddler syndrome. They pulled the whole lead out of the heart. But what you do see up on here is the coil, which is a defibrillator coil, that thick part right next to the end of it. And then I'm going to show you my favorite patient of all time. And he had a pacemaker about 5 years. But he had apparently dog breed like this. I think it's a pit bull or bulldog. They have the issue with complete heart block. So they have cardiac electrical issues, and they put pacemakers in these dogs. He had to put down in Alabama, the University of Alabama. But God, it was so much fun going and checking that pacemaker. So that is it on that. I'm going to go through temporary pacemaker. A few good facts here. On the temporary pacemaker, if you need an emergency situation, red button right there, if you press that, it turns on. All right? You just got to press and hold it for a second. So you don't have to mess with anything. It automatically dials the outputs to the maximum. because we're not worried about outputs at this point. We just need an emergency situation. We want it to work. I don't care which one you plug this into. Both of them are going to work because both of them are on. All right. Now, there is a, try to get this online here. There is a lock key here. So typically, if it's been on for a little bit, you're going to have to hit the lock key. But it's going to tell us down here that it is an asynchronous pacing. To get it out of the asynchronous pacing, that asynchronous pacing means that my sensitivity is set to not see anything. So my fence is all the way up. I don't care what's behind there because I don't want to see it. I just want to pace. So those are emergency situations. So what we do have to do is turn our sensitivity back down and be able to dial that down. So turn your sensitivity back down. That's going to be in your bottom section here. If you want to make this a VVI pacemaker only, just go ahead and dial down your atrial output. You can dial it all the way down. And then all of a sudden, you have a VVI pacemaker. The other key aspect here, and I just want to make sure I say that it is right here. So the battery in the back compartment here, good for 7 days. And you have 30 seconds. The pacemaker's still going to continue to work while the battery drawer is out. So you have 30 seconds to change the batteries if you need to. After the battery indicator light comes on, you do have 24 hours left on that. And there is a pause key down here at the bottom. If you press and hold this, it will last up to 10 seconds. So you can make somebody pause for 10 seconds if you need to. You'll freak a lot of people out, which is kind of what I try to do whenever I come up and see a pacemaker. I try to sneak in and be like, I'm going to check this pacemaker without the nurse knowing and pause the heart rate and see if I can get people excited. The last thing I want to show you guys is if you need a pacemaker check, we have iPads and they are located in the CVU, emergency room, cath lab holding, PCU, and ODU. I did not put one in the ICU because you guys typically are not the ones who get all the pacemakers, but occasionally you do. Sometimes you need a pacemaker interrogation. But if you go grab an iPad or call somebody from the CVU to come do it, if you press the button, you're going to type in, and the password is super hard. It is right there for you. All right, capital M. And you're going to find this CareLink Express, CL Express. You're going to open that up. You're going to hit start. We're going to take our finger and we're going to turn this hand reader on. And right now it's searching for it, so my blue light is blinking. They're pairing up. It's asking you to find the pacemaker now. So we're going to set this off to the side. Set it over the top of the pacemaker. And it's going to bring up, hey, is this what you want to pull up? Because they're wireless telemetry now. So it wants to make sure this is the only one here. So yep, it's got to be the right one. So I'm going to hit continue. It's saying it's getting signal from it. And it shouldn't take too long to download.
If multiple come up, does it have like a name or something on it? Or how do you?
Yeah, so sometimes it'll be like a pacemaker and a loop recorder in the same patient. And you're going to say, which one do you want to interrogate?
Okay.
So some patients still have their loop recorders in because we didn't take them out. So you're going to choose the pacemaker over the link.
Okay.
It's not going to pick up the neighbor patient's.
Yeah, not the neighbors,
Okay.
but we have multiple
That's
wireless
what
in
I
them.
was saying there. I was like, oh, that's gonna be fun.
There's 70.
So it tells you can take it off and put it away. And at this point, you can take everything and put it back away because it's going to send it itself. And it says your data is sent. This is now going to send me a page. And I can look at that full pacemaker interrogation on my phone no matter where I'm at. So like today, I'm over in clinic all day. I'm not going to get to any patients in the hospital. So if you're needing a pacemaker interrogation, I can look at it right there and be like, hey, this is what's going on. Or I can be like, yep, I got to leave clinic, cancel some patients, take care of this because there's an issue. Defibrillators, real quick on those. You can see that there's a considerable difference there of a defibrillator versus pacemaker. So if it's up here, you can probably feel if it's a defibrillator or not. Magnets, you guys have a magnet on each one of your crash carts. Magnet over defibrillator deactivates the defibrillator part of it, keeps it from shocking. The pacemaker function still is exactly the same. You're not turning off pacemaker. Pacemaker, a magnet over the top of it, you blinded it and you forced it to pace. And it paces at a slightly higher outputs than what it was. But all you did is force pace it. Why do we do that? Because when patients go into surgery and they had a pacemaker and they're 100% dependent and they're using cautery, external noise, the pacemaker goes, oh, you got your own heart rate, and they get long pauses. So in reality, they put a pacemaker over the top of it, they blind it, they force pace while they're in the operating room, and then they remove it. And this defibrillator, put a magnet over the top of it, it keeps the patient from getting shocked while they're in surgery, because the defibrillator is like, hey, that's a life-threatening arrhythmia, let's shock you. And you know, the physician gets a little upset because he was cautering and the patient jumps, and then he just nicked the whole bowel and the bowel's gushing out in there. So magnet over the top of defibrillator is important. Patients dying, don't worry about pacemaker. Don't do anything about a pacemaker. Pacemakers do not prolong life. Defibrillator, put a magnet over the top. And there's alarms in there too. So if you hear an alarm going over the top of it, a long steady tone or European siren, you're over the top of it. Good job. All right. If you didn't hear an alarm, it's probably not a Medtronic and it's another device, but regardless, put a magnet over the top of it. If you're not sure which one it is, put a magnet over the top of it, because you didn't hurt anything by forced pacing. You did hurt them if you didn't put a magnet over it and get them shocked and they was trying to die and you just brought them back to life.
So if a patient is dying and now the pacemaker's going to keep going, we're going to see that for them on the monitor.
You will.
They're not going to go asystole.
They will go asystole. You will see pacemaker spikes only.
Okay.
It's
not going to be like a PDA or anything.
And it's possible that you will get that for a little bit,
Okay.
but eventually you'll get asystole with pacer spikes only. And then they go to the funeral home. Funeral homes will cut out a defibrillator typically, but sometimes those alarms, if you let me know that a patient has passed or something like that, I'll come turn off those alarms, because I've had it where in the middle of a funeral, the alarm's going off, and it's going, and, you know, it's a little disrupting during a funeral, to say the least. Yeah, like, oh my God, step back from the casket. Something's bad going to happen. But that's pacemakers and your temporary, kind of in a nutshell, and a little bit quick there at the end. So, questions? All right. Well.
So you don't have anybody that can take call for you if you really want to check out for a little while?
This CareLink Express.
Yeah. There's a lot of that.
I take Wednesday nights and every 7th and 8th weekend, but I take it for Quincy, Hannibal, Decatur, Champaign, Bloomington, and Effingham. So everybody with all those little hospitals in between there too. So that's Carthage and Memphis, Missouri, and every little hospital. So somebody shows up with a pacemaker, I get those pages, and it's probably 2-3 times a night that I have to take a page, and it's probably about 5 or 6 times during the day. But when I'm not on the 7th and 8th, those go to somebody else. So that's why it's like, it's easier if you do this, because I have more of a life. You know, weekends 1, 2, 3, 4, 5, and 6, I can have a little more of a life and do things instead of being like, hey, Andy, there's a pacemaker check. Well, did you use the iPad? No, we don't know how to use that. Well, why don't you find somebody that does? Because I kind of want to do stuff. So your next up looks like Mr. Waylon Nutter.